Hi, this is Manos Brilakis, and this is case 171 for the Manual of CTO Interventions. This is the longest case that I have ever performed. The patient was an elderly man who had significant peripheral arterial disease as well as some exertional angina and fatigue. He was in need of peripheral revascularization. He had a stress test that showed an ejection fraction of 35 to 40% with multiple wall motion abnormalities, followed by coronary angiography that demonstrated an ostial occlusion of the left anterior descending artery with heavy calcification. There was also ostial disease in the circumflex and disease in the distal left main. And there was potentially a filling defect in the distal left main, potentially due to calcium artifact. Also, there was a lesion in the mid-right coronary artery that was also heavily calcified and tortuous and was providing collaterals, septal collaterals, that were filling the LAD. This is a peripheral angiogram showing a significant left common iliac lesion that will become important, as we'll discuss later on. There was also diffuse iliac and femoral disease. The patient had a cardiac MRI that showed viability in most of the myocardium. And after he was seen by cardiac surgery and turned down for surgery because of frailty as well as significant PAD, he was referred for percutaneous coronary intervention. The biggest challenge in this case was estimated to be the ostial LAD CTO. But to treat this, we knew that we were likely to go retrograde given the ostial occlusion. At the same time of treating the LAD, we would need to treat the circumflex. So have a blunt proximal cap, length of about 40 millimeters, but it is hard to see the distal vessel. The distal LAD is diffusely diseased and fills from sepals from the right coronary artery. Therefore, our plan was to do PCI of the right coronary artery, followed by an IVUS-guided attempt of crossing the proximal LAD, followed by retrograde crossing. We obtained right femoral access, and then we also obtained right radial access, trying to avoid the left femoral because of the iliac stenosis. However, we were unable to engage the coronaries, and as a result, we obtained left common femoral arterial access. These are the baseline hemodynamics. The patient was hypertensive. There is early repolarization on the red EKG lead. Wiring the right coronary was challenging. This is an 8 French AL1 guide catheter. We had very difficult time advancing a guide wire. Eventually, we used a microcatheter, a caravel, along with the Suoh 3 guide wire, successfully crossed, but we could not deliver a balloon, and as a result, we switched for a Viper flex tip wire and performed several runs of orbital atherectomy. This improved the stenosis, and we then were able to deliver a balloon that seems to expand well. We tried to deliver a 3.0 by 38 millimeter drug-eluting stent, but the stent would not cross to the mid-right coronary artery. As a result, we used a 6 French telescope guide extension, and after doing that, we were able to deliver the 38 millimeter stent to the mid-right coronary artery. The stent was deployed, and that provided a nice result. There is still disease in the more proximal portion of the right coronary artery that was covered with another drug-eluting stent, 3.0 by 26, and that provided a nice result after post-dilatation. At this point, we debated whether we should continue with PCI of the LAD CTO because there had been 1.5 hours of procedure. But given that we had dual access, we had used minimal contrast at this point, the decision was made to proceed with the attempts to cross the LAD. We used a Corsair XS microcatheter, and along with a Suoh 3 and then a Sion black guide wire, that after a while it took several attempts to engage the septal, but eventually we were able to advance the guide wire in what seems to be the course of the left anterior descending artery. This is exchange for an XTR and the Suoh 3 again, and we performed an injection from the right that clarified the location of the septals. And eventually, using the Suoh 3 wire, we were able to advance all the way to the LAD. Now we're going undergrade. However, we were unable to advance the Corsair XS. We used a telemark microcatheter that did not go, but eventually, after multiple attempts, we were able to advance a Turnpike LP microcatheter all the way to the LAD and performed a tip injection. We then did another tip injection that was very useful because it demonstrated that fortunately there was enough of patent LAD proximal to the origin of this septal branch, which facilitated our retrograde crossing attempts. And at this point, we've been doing this for about 3 hours. We were able to advance a gladius mongo wire retrograde. We had difficulty advancing more proximal due to significant calcification. Eventually, we did another injection with the catheter advanced as far proximally as possible. And then eventually, after multiple attempts and multiple wires, we were able to advance a filter XTR in what seems to be the course of the proximal LAD. This is an undergrade injection. We are seeing now that we have clarified the ambiguity of the proximal cap. And then we tried to wire undergrade with multiple wires. Eventually, we're using a dual lumen microcatheter, a Sasuke, and a guide third wire. We were able to advance the wire subintimally into the LAD, and now we have the undergrade and the retrograde wires overlapping into the proximal LAD. We were trying to get an undergrade guide extension 6 French telescope a little further in so we can do guide extension reverse card, but we had a very hard time to do so. We were unable to advance it in because of the significant calcification, despite multiple predilatations. And eventually, during those attempts, we noticed that the tip of the telescope, the guide extension, was actually not moving when we were trying to move it. So what had happened is that the tip of the guide extension had fractured and remained at the tip of the guide. We used the small balloon technique in an attempt to bring it back, but despite doing the inflation of the balloon and pulling it back, we're unable to actually bring the tip of the telescope back into the guide catheter. We eventually decided to remove everything, so we inflated the balloon and then brought everything back all the way out. But then unfortunately, as we were trying to move it back, it came, and then when it hit the tip of the guide, essentially what happened is that the fractured tip of the telescope bounced off the tip of the sheath and embolized in the iliac artery. At this point, the patient is doing okay. There's maybe some hint of ST elevation, but he was not having any chest discomfort, and his pressure was good. We re-engaged, and we were able to rewire into the LAD. We used the 6 French Godzilla guide extension, and then we were able to do successful reverse card. And now we have crossing of the lesion at 4 hours and 20 minutes after the beginning of the procedure. So clearly a very challenging case, but at this point we thought that we were getting closer to being done given the successful retrograde crossing. We were unable to advance the microcatheter, the retrograde microcatheter, but using a new one, we were able to get it into the undergrade guide, and then we externalized an R350 guide wire. So we now had a fairly strong support for undergrade delivery of equipment. However, at this point, the patient started having some chest discomfort, and we saw ST segment elevation in both the yellow as well as the red lead. We took a picture on the right side, and we do have a filling defect in the distal right coronary artery, distal to the previous stent, which is hard to know what exactly caused this. It could have been distal edge dissection. It's unlikely that it was thrombus because the patient had therapeutic ACT throughout the procedure. So we thought we'd put a stent. We have now externalized guide wires, so therefore very strong support. But unfortunately, we were unable to do so. It was very hard to deliver, even though we still had an undergrade 6 French guide extension. We advanced the undergrade guide extension further down using the inch-warming technique and tried to deliver a 3/0 by 28 stent that did not go. And then a 3 by 26 that also did not go, but then when we were trying to remove it, it was stripped off the balloon and embolized in the right coronary artery. So now we have the situation with a lost stent. The patient is having ST elevation, poor flow. We decided that retrieving the stent would be very unlikely, so we deployed it. But then we had a lot of difficulty. Couldn't deliver any balloon through the mid-right coronary artery. At the same time, while we were pushing, we noticed that we were moving the telescope, but the tip of the telescope also did not move. And ironically enough, we had the exact same problem we faced in the LAD. We had fracture of the tip of the telescope guide extension. You can see here now the STs are pretty high, both in the red and the yellow leads. So that's hemodynamics are okay, but we're really concerned about this. So we did use a lot of balloons. Eventually a subfire could go a little further down. And eventually we were able to deliver a 225 by 30 millimeter balloon. And that restored better undergrade flow to the right coronary artery. We then thought that we would try to get an undergrade wire, so we used the dual loop microcatheter to advance a guide wire into the LAD. And we thought we would remove the retrograde gear. That did not seem to help us actually with delivering equipment on the right coronary artery and stents. We ballooned the LAD, but we were unable to actually remove the retrograde guide wire. And after finally using multiple balloons, that many of which ruptured, we were able, using a Godzilla guide extension, to advance a balloon and a stent down to the distal right coronary artery. This is a 3 by 15 millimeter stent. And that helped actually restore the flow. But now we have the same problem here. We have the fractured tip of the guide extension. We were planning to try to remove it, but the tip actually subsequently embolized distally, and subsequently went even more distal into the right posterolateral. But I guess at this point we had bigger fish to fry, so we wanted to complete the procedure as soon as we could. After we stented the distal right, we were able to remove the retrograde equipment. And then we can see now that we do have okay flow. There's still an area that doesn't look perfect distally, but at least the flow is TIMI3. The ST elevation got better. We also have guide wires into the LAD as well as in the circumflex. We were finally able, again, multiple attempts, multiple balloons, to deliver another drug-eluting stent to the distal right coronary artery. And at this point, we felt good that we had covered that area of potential dissection in the distal right coronary artery. And now we're 7 hours into the procedure. STs are still fairly up, but the patient's chest pain went away. So now we have to finish fixing the left main, LAD, and circumflex bifurcation. We decided to use a double kissing cross, given the extensive dissection and the disease. We used a 3 balloon into the circumflex. There is, again, dissection into the LAD, but good distal flow. We stented first the mid-LAD, and then we placed a long drug-eluting stent into the circumflex that was considered the side branch for the purpose of DK cross. It was deployed, and then after deployment, it was crushed, followed by ballooning of the LAD, and then did the first kissing balloon inflation after rewiring the circumflex. We did have difficulty delivering the LAD stent, but using a Godzilla, we were able to deliver a 3.5 by 28 millimeter to the LAD, overlapping the previous stent, and that was successfully deployed. There was some post-dilatation. We did a pot with a 4.5 balloon, rewired, and did the second kiss balloon inflation. So at this point, we felt pretty good. However, a couple of things we noticed now. There is this area of staining in the mid-LAD outside the stent. Also distally, there is some haziness concerning for possible distal LAD dissection. And the left main, also the ostium of the left main doesn't look perfect either. We did an emergency echo at this point that showed unchanged function, and there was no pericardial effusion. But we decided to cover the distal LAD, so we placed a 2.5 by 12 millimeter drug-eluting stent. We still had some chest discomfort and ST segment changes. We were not sure if this was responsible for those, so we decided to cover it. And fortunately, we were able to deliver a 3.0 PK papyrus stent into the mid LAD. After doing that, now we have no more extravasation or staining in that area. There is still good flow. But then we're still concerned for the ostium of left main, so we cover that as well with a 4.0 by 8 millimeter drug-eluting stent. So here we are now. We do have good flow in both vessels. I think we've covered it fairly well. And even though it's been 8.5 hours and 375 mL of contrast, we thought that we were done. The patient was feeling okay. He did not have any chest discomfort. There was still some ST changes, but he was feeling okay. So our plan was to monitor him in the intensive care unit. However, the legs appeared to be cool, and he was known to have significant PAD. And also, in the radial axis, we had difficulty engaging. There was a hematoma on their right arm. So we called the vascular surgery, who came in, performed angiography of the leg all the way down to the foot, but there appeared to be okay. So it was decided to pull the seats and hold manual pressure. However, when the seats were pulled, then there was formation of a large hematoma on the right groin. At this point, the patient started crashing. He did have significant hypotension. You see the systolic is down to the 80s. We still have ST changes, ST elevation in the red as well as the yellow lead. We obtained access urgently on the left side and then went back, and we saw that actually there was still good undergrade flow in the right coronary artery and the left coronary artery. But the patient subsequently deteriorated, and then we ended up doing CPR. We placed the Lucas device. This is the pressure waveform with the Lucas device. At this point, things did not seem very good, so we decided to place the patient on ECMO. While the preparations were made, we took another angiogram. We can see this is done now under CPR. And we thought at this point that there was an occlusion of the LAD, potential stent thrombosis. The patient is intubated at this point on inotropes and vasopressors. And then eventually we were able to put him on ECMO. Both cannulas were placed through the left groin. However, there was poor flow, and the reason for that is because the patient had a significant lesion in the beginning of the left common iliac. So now there was a need for switching the arterial cannula to the right to allow a good undergrade flows of the ECMO. Although the patient hemodynamics again stabilized after he was placed on ECMO. So the right side was stented. We did do a Swan-Ganz catheter that demonstrated very low pressure, so clearly the problem was due to poor filling. This is the wedge, which was close to zero. So the patient deteriorated because of significant bleeding. There were still, however, EKG changes, but the echo was unchanged, showing normal ejection fraction and no pericardial effusion. It took quite some time to be able to repair the right common femoral and iliac, and actually a graft was shown to the right common femoral to use for inserting the ECMO cannula. After all this was done, before switching the cannulas, we actually did an angiogram. The right, fortunately, looked okay. And actually, to our pleasant surprise, the left was also fine. There was good undergrade flow in the LAD and the circumflex, and there was no concern for stent thrombosis. I think what we had seen previously was likely the result of poor undergrade flow because the patient was in shock. So the cannula was moved to the right side, and then the patient eventually went to the unit. It took 15 hours of procedure time from the beginning all the way to the end. The patient did receive blood transfusions, and he did have a long hospital stay. However, he was decannulated 4 days later. His ejection fraction was normal 5 days later. There was no neurologic deficit, and he was extubated 6 days later. And he finally was discharged to rehabilitation 18 days later. This is the ejection fraction, the echocardiogram, showing that the cardiac function was okay. So there are multiple lessons from this case for me. One is the importance of humility. This is a case that we never expected to turn out the way it did. There were multiple complications. We did have acute vessel closure. We did have staining suggesting of perforation. We did have edge dissections. We did have access complications, both in the legs and the arm. Fortunately, the arm was not anything serious and there was no intervention needed for that. But it reminds us how many things can go wrong and the importance of being humble and attentive and trying to do the best that we can. The second is the need for stamina. This was literally a 15-hour case, so it took a lot of effort from the entire team to be able to effectively navigate through all the challenges. And it was also a very challenging case because of the EKG changes, the questions with hemodynamics, then the need for support, initiation of ECMO. So multiple things that kept the entire team literally on our toes while trying to do the best for this patient. Retrospectively, should we have stopped after stenting the right coronary artery? Maybe, but of course it's always easier to say things post hoc. A fourth lesson is the importance of the team effort. Complex PCI is no question the result of a collaborative attempt. We're very fortunate to have a highly dedicated and skilled team that night, both from our team as well as the vascular surgery team, as well as the intensive care team and the perfusionist team. So it takes a village for performing complex PCI, especially when things don't go well, as in this case. Another lesson is the implications of severe calcification and tortuosity. This made the case much more challenging. We had to do atherectomy. We had edge dissections, which were likely, at least in part, due to the calcification. ST elevation is what happened during the case. Part of it was due to the distal RCA developing a filling defect, possible a dissection. But there remained ST elevation at the end of the case, even though the patient had normal ejection fraction and we did have a good flow down all three coronary arteries. So it is hard to know exactly what caused it, but over the next few days, that subsequently resolved. Another lesson is the importance of having algorithms for treating complications, algorithms for acute vessel closure, for perforation, for hemodynamic instability. Another lesson is the importance of not pushing stents too much when there's difficulty delivering. About 2 of the hours of the case were actually spent trying to recover from the stent loss that happened in the right coronary artery, and that made everything very challenging with subsequent equipment delivery. Another unusual occurrence in this case is the fracture of a guide extension tip. We have had guide extension tip fractures in the past, but this was ironic in this case that 2 guide extensions, both in the left as well as in the right, fractured and embolized distally. We were able to remove the first one from the coronary tree, embolized to the periphery, but we decided to leave the second one that embolized distally in a small branch. Lesson number 10 is the importance of VA ECMO when things don't go well and the patient goes in essentially cardiac arrest. VA ECMO is often the only way to salvage them. So having access to VA ECMO on an emergency basis 24/7 in the cath lab can literally be a life-saving procedure in the lab. Finally, we did have a team debrief a week later that we discussed our experience with the case. That was an extremely useful experience, discussing about what happened, what we did well, what we could have done better, and I think brought the team together and helped us consolidate our learnings, vent our feelings, and hopefully prepare for doing a good job for future cases to come. Thank you very much.